πρώτη παρουσίαση είναι lecture από τον καθηγητή κύριο Ντάγκα. Θα μας μιλήσει σχετικά με τη Στεφανία Νόσο 2025. Σας ακούμε.
Ωραία. Ευχαριστώ. Είναι η προηγούμενη ομιλία, δεν είναι αυτή. Ενώ τα slide ξεκινάνε, να ευχαριστήσω τον φίλο μου τον Γιάννη, τον Ιακώβου, ο οποίος είναι διευθυντής τώρα εδώ στην Επαγγελματική Καρδιολογία στο Νάσιο, και βέβαια τους δύο συμπροέδρους, τον Γενικό Διευθυντή εδώ του Ονασίου Καρδιολογικού Τομέα, τον κύριο Εφρεμίδη, και τον Γενικό Διευθυντή του Καρδιολογικού του Ευαγγελισμού, τον κύριο Τρίκα. Και με πολύ χαρά επίσης να δω ότι και είναι ο συμφοιτητής μου, ο κύριος Βλαχόπουλος, βρίσκεται εδώ μαζί μας και την επόμενη ακριβώς εισήγηση. Λοιπόν, θα σας μιλήσω σχετικά με την Στεφανία Νόσο. Βέβαια, ήδη καλύψαμε πάρα πολλά για τη Στεφανία Νόσο. So I'm going to change to English because we have also the internet attendees, and we welcome their questions and their comments in the chat. We want to focus on the most recent developments because all of you are very advanced in coronary disease, and I don't want to go into the basics. So let's go, first of all, to see if we had any statement by the societies. We have to be very serious about those statements. And we have the very, very recent, hot off the press, 2 months ago, the acute coronary syndrome statement by multi-society, ACC, American Heart Association, American College of Emergency Physicians, and including also the Society of Cardiovascular-kidney-metabolic Interventions, of which I'm very happy to be the immediate past president at this point. So please study those statements. They include a lot of very, very important guidelines we have to abide with. The most important we have to think about is that we're really talking about LDL of 55 now in very, very seriously. All right, think about those things. Is a major development. And again, why? Because Professor Kokkinos and others already said before, in order to have the good results later on, you really need to attack the secondary prevention risk factors aggressively. Otherwise, our results, either surgical or interventional, will fail. It's like you're playing a game. It's not enough to score. You're excited when you score. If you don't play good defense, you're going to lose the game. Well, that's how it goes. And you can see the very important guidelines that we have, the new recommendation, the non-infarct-related artery is recommended for an immediate PCI or immediate planned PCI, I should say. You don't have to do it immediately the very same day, but this is a major change. It used to be a class 3, never do it. Or then it went maybe to B, do it if a positive stress test in a few months. Now it's a class 1 to do it. You have 2 lesions, 1 culprit, you fix it. Non-culprit, plan it. Whether you do it right now or in 3 days in the same hospitalization or in 1 month, well, that's up to you and as you assess the case. I usually do it either within the next day or immediately, if it's 95+%, or if not, I wait, because for many other studies, we know we can wait. And usually the wait is 1 month. Another interesting study, because we're focused a little bit on long-term in the previous discussion, so let's talk about long-term. This is the final 5-year follow-up of FAME-3 trial, FFR-guided PCI versus bypass surgery based on coronary angiogram. This is stable patients, not involving left main, and patients willing to be randomized. It's not in the United States, so it's mostly in Europe and South America, and you can see that in general, the death from any cause, 16% in PCI, 14% in bypass, very, very similar. And regarding the secondary endpoints, the most important was, of course, the repeat revascularization that was higher after the PCI. But aside from that, no difference. And this is with the FFR-guided PCI. So that's what we practice these days. A lot of comparisons recently. 2024 was a year of intravascular imaging. So many ways. The Flavor 2 trial was presented just 2 weeks ago, 10 days ago, in the ACC 2025 in Chicago. This was nearly 2,000 patients with CAD, well, at least 50%. They were randomized, and they stratified it according to diabetes, so there's not any funny mismatch about diabetic. Into angio FFR guided strategy and to IVUS guided strategy. According to the targets that you see here, the MLA less than 3 or the MLA between 3 and 4 and plaque burden over 70%, they perform revascularization. And the FFR cutoff is very clear, 0.8. And you see that in general, it didn't really make a difference. So I think that answers some questions that we have. We do IVUS or we do FFR, what do we do? How do we mix and match? The cutoff of IVUS was 4, and that created a little bit of a differences. But if you drop the cutoff to 3, that's what they did here, then you have a very good agreement. So if you make the IVUS cutoff a bit stricter, then you can use either essentially. And the flavor here is that the IVUS gives you some more intraprocedural information, such as the sizing, the length, the calcification, the planning of the procedure. So it may allow you also to not have to spend an extra dollars, extra euros in order to use the FFR for the indication. So if the IVUS goes to 3 millimeters square, it's a new cutoff. That's what the study indicates. Then you're pretty good that this is going to be very significant by FFR as well. Another aspect is we talked a lot about the secondary prevention, and I've done a very important study here. We have the Smart Choice 3 that said, okay, the patients had PCI, and should we give them aspirin or should we just give them clopidogrel later on? And are we going to have a better defense team if our defense team has clopidogrel, or who go with aspirin the classic way? A very important study that indicated that in the long term, clopidogrel is going to be beneficial. But look at these curves. It's not going to be beneficial in an appreciable way right now. So in the longer term, beyond 3 years, beyond 2 years, you start to see some effect. Is it as pronounced as it shows here? This is nearly a 30%. I don't believe so, because you also see that there's a drop-off in the number of patients followed up. So the benefit is realized in the longer term. I think we know that in the medical therapy that doesn't have tremendous immediate results, but it's a more longer term. And more importantly, the bleeding was identical. So although in our mind, the dual antiplatelet therapy with aspirin and clopidogrel has a lot of bleeding, the monotherapy doesn't seem to have a lot of bleeding. And in fact, one can say there may be some non-GI bleeding that's a little bit higher with clopidogrel, and the GI bleeding seems to be a bit lower with clopidogrel. And therefore, they kind of balance out the risks. Very important. And talking about dual antiplatelet therapy, the Koreans did a study that compared shorter versus longer DAPT regimens. In the high bleeding risk, the short is 1 month and the long was 3 months. And in the low bleeding risk, the short one was 3 months and the long was 1 year. So it's a little bit different duration according to the bleeding risk, but the flavor in general, they wanted to lose short versus long. Obviously, you can see the different designs here per group makes the study a little bit complicated. But most importantly, this study is in Korea, and in Korea, East Asia patients have a very different genetic background regarding clopidogrel activity and all that. So even the authors and the speakers, they acknowledge that this is really not generalizable in our populations here. But even the results that you see that overall the results were important in that the shorter had a little higher adverse events in the thing. So they ultimately decided that the shorter lost in the high bleeding risk and the shorter won in the low bleeding risk. So regardless of the bleeding risk, their outcome was you give it for 3 months. So it was an interesting scenario in the end. Again, there's many limitations in the study. A very important, interesting study here has nothing to do with intervention, but it's very important. We heard from Dr. Alexopoulos earlier, his comments about Minoka, etc. And this is exactly a study like that. It's a warrior study presented just 10 days ago at the ACC, 2025 in Chicago. And these are patients with clinically stable women with angina. And they have no obstructive CAD, but they do have some CAD. Well, it's not normal coronaries. They have some CAD, not non-obstructive, and as confirmed by angio or CCTA. So they randomize them to usual care, which is maybe not do too much, or minimal therapies, versus a very high level, intense medical therapy at the level of as if they had, let's say, PCI. The intense medical therapy was a high-intensity statin or PCSK9 plus an ACE inhibitor, an ARB plus a low-dose aspirin. I think the usual care could be perhaps maybe just the aspirin or maybe just some sort of statin, but not very clear criteria. Interestingly, it didn't really matter a lot. So in the 5-year horizon, and again, there's a lot of dropout after 3 years, so we can perhaps say in the 3-year horizon, it didn't really seem to matter. So perhaps in this population that is non-obstructive CAD, the intense medical therapy versus the modest medical therapy, not so much. Of course, on the other hand, I haven't seen exactly what the usual care included, because if the doctors they were very active in the usual care, maybe the two groups converged as far as what kind of treatment they are. I must say it's a little bit of a disappointment in the INOCA community. I think the investigators and all the experts, they were anticipating that there would be a tremendous benefit in this population by aggressive risk reduction. Let's go back to interventional, because after all, it's an interventional meeting. This is another study presented at TCT 2024 in October, and this was about calcific lesions, moderate to moderately severe, not super severe in stenosis, in that no catheter would go through. So you have to be able to pass a balloon somehow. So let's not think about those catheters that nothing passes and you need to use a rotablator for sure. So this minority of cases that is 95% calcific lesions, nothing goes through, are not part of the study. In this study, they use the orbital atherectomy, which is a little bit of a milder and easier to learn atherectomy technique, perhaps by many are viewed by not so nervousness by the operators or by the new operators and the rotablator, that they feel like, maybe jumps and creates a complication. It's a little bit more controlled atherectomy versus balloon angioplasty. And let's see how it goes. The interesting part of this study, though, was that for the first time, such a study that is not focused on imaging had about 65% intravascular imaging. Just because the doctors in the study, they wanted to use imaging, either IVUS or OCT. So that's unlike any other study thus far. Typically, you do the studies that are not imaging studies, you get intravascular imaging between 10 and 20% at best. You don't get more. Over here, we had 65%. What does this mean to me? That perhaps the balloon was super optimized because you learn a lot about under expansion and you really use more balloons, etc. To make the long story short, with the utilization of liberal imaging, really it didn't pan out that the orbital atherectomy was any better. And particularly, it did show that the balloon angioplasty median result was about 7 millimeters square, which is outstanding result. This means that the vessel became really big, and with the imaging, it is the imaging perhaps that made the control group so good that the orbital atherectomy didn't have a chance to make anything better. Also, the orbital did not really shorten the procedure. So in general, I think it's reserved again for the more severe lesions that perhaps the balloon is not an option up front. That's interesting. Anyhow, another item that in general I wouldn't include, but I know there is a lot of experts of colchicine in Greece, participation with many papers of the European Society of Cardiology. This study, though, a very large study, 7,000 participants, patients who after MI and utilization of colchicine and spironolactone. This is the colchicine results. It didn't pan out as expected, and the spironolactone did not pan out as expected either, so it was a lose-lose proposal in this ambitious 2x2 analysis, and I think that's a step back for the enthusiasm the colchicine had created in other studies. And again, this is a mixed acute ST elevation MI as well as non-ST elevation MI. So in the broader scheme of things, perhaps a non-specific anti-inflammatory agent of colchicine is not as good as we thought it is. And perhaps we have to only think about it in the ST elevation MI population. I'm not sure. I look forward to see that secondary analysis of this study. And similarly, I would like to see if spironolactone only is applicable in patients with decreased ejection fraction. I look forward to that secondary analysis as well. Finally, I kept a final study because my friend Goran was here. The European Bifurcation Club had finally a randomized study and dedicated for treatment of true left main bifurcation lesions, the EBC main study, about 500 patients. True bifurcation lesions means that the side branch is heavily included and the lesion is not superfocal. Means both of those. So you have a significant in tightness as well as significant in length lesion in the bypass. In this case, I randomized the patients into upfront dual stent strategy versus a provisional strategy with a well-planned how to place the second stent by a reverse mini crash technique for the most time. Interestingly, the provisional stent seemed to be, again, the winner, but primarily by the decrease, as you see, of MACE, and particularly when the side branch is greater than 10 millimeter on the right bottom, you see that the provisional is actually worse. And I think that's an important matter that we have. In general, provisional did very well, but if you really go to a lesion that is long in the side branch, you're not going to do well starting within a few months after the procedure. So I think my take-home message is that in the lesion length more than 10 millimeter in the significant side branch, it's a win for the dual stent system, practical reasons. And I see no variability. As you can see, the only variability, one before the end in this area, is the stent length had a significant interaction, as well as the stent diameter when it's very large, over 3.5. So a large side branch with a long lesion, that is a significant advantage for an upfront dual stent approach, coming particularly from the European Bifurcation Club, who always have been a proponent of the provisional single stent only. We saw some Impella procedures earlier today. Of course, it's a very expensive solution. I know the CFO of the hospital indicated that we got to be cognizant of how much a procedure costs. But for the first time in, I don't know, many decades, there was a positive trial for a mechanical circulatory support device. And I may say a comment about that. Why is it so many decades? It's very difficult to do a study. When someone is in shock or has a terrible ejection fraction, very impossible to randomize, quite frankly. I mean, the patients are nearly dying, the patient will be very acute, everybody's going crazy in the family, the doctors, and in the middle of that, the research team comes and says, oh, okay, let me randomize. Are you going to get this or are you going to get that? And nobody's listening to them. So it's very difficult to randomize patients. And sometimes also you randomize patients that you don't have any immediate answers. So you randomize only the super morbid patients that you really don't want to treat with a hemodynamic. So there's a lot of bias from the patients, from their doctors, and from the proceduralists. Sometimes you feel, okay, I have a device here, I'm going to use it because this patient is really critical. And at this point, you're not even thinking yourself, let's randomize. So all the trials are a little, I should say, convoluted. So in this environment, the Danish group had a very small country and also a very disciplined country. They decided they're going to control this off-label utilization or clinical utilization. They're going to, I don't want to say force, but for sure highly encourage people to just go like that. So, and I think they have the setup to do that. And we know from the dynamic trials also, they're really very, very disciplined. All of Denmark follows the similar pathway. We don't have a lot of variability like the Mediterranean countries. People like to do their own thing. They don't like to do their own thing. They're very focused. Of course, it's a small country, so things take a long time. So they ultimately included some German countries, some German centers. That's why the Dan shock became danger shock. It's not danger. I guess the patients are in danger, but it's a danger shock trial. And let's see how it came about. There was a lot of hemodynamic, there's a lot of hypoperfusion, the lactate was high. There's a lot of LAD or left main. And there's a median age was about 67, so they weren't very aged. The median ejection fraction was 25%, so half of them were in the 20 or less. And the SCAI, Society of Cardiovascular Angiography and Intervention, classification of shock was mostly C, and if it wasn't C, it was D or E. So it wasn't A or B. It wasn't ambulatory patients there at all in any ways. And you can see there was a significant reduction of the primary endpoint, which was all-cause death by 6 months. And that is exactly the time point selected by the original shock trial 20 years ago, 30 years ago maybe. So that's how they got it. The original trial actually had a 30-day endpoint primary. They did not meet that. Everybody thinks the shock trial was positive. It was negative. It became positive in the secondary endpoint of the 6-month follow-up. So learning from that experience, these investigators chose a 6-month follow-up with a 30-day secondary follow-up, and again showed the similar thing, a trend at 30 days and a significant reduction by the 6-month time point. And you can see various endpoints and other ways to measure things. It wasn't an overwhelming win, but it's definitely a win, and that space never had a win, so I think it's a little bit overrated in some ways, but nonetheless, it's a positive trial in this population. One of the adverse events, some of the adverse events is these patients had a renal hypoperfusion. And you can say, okay, why the patients have more dialysis or more Prisma, they go and say CVVH, how come this goes the other way? Well, in some ways, you have to support the patient in order to avoid a death. So somehow the patients lived longer. They had to sustain themselves through some bleeding. You put in a 14 French device, and including perhaps some ultrafiltration in higher rates, ultimately in order to save some lives. So you have to go through dire straits. This population is very sick. Ultimately, had a good outcome as far as the mortality. So finally, don't want to show all the results about the Twilight study and others. This now has become the ticagrelor monotherapy after an initial dual therapy has made the guidelines in class 1A based on the pioneering study from Mount Sinai, the Twilight, and followed by several other studies going the pathway of stopping the aspirin a couple of months after the initial procedure. Thank you so much, and this is our next conference of Society of Cardiovascular-Kidney-metabolic Interventions. You can all join at sky.org. In Washington, D.C., And at the same time, don't forget that TCT, to, October 25-28, in San Francisco is a little bit far, but obviously any participation from Greece always one of the highlights of the meeting. And in case you want to travel somewhat shorter, we have a valve course in New York, June 25-27, shortly after the valve course right here at the Onassis Heart Center. Thank you very much for your attention.
Thank you very much for this comprehensive lecture. We have time for only one question or comment from the audience.
Okay, George, thank you very much. Excellent and informative talk. So I was looking at the numbers as you suggested in the ECLIPSE trial. So it's to have a balloon stent-like result with more than 7 square millimeters. If the lesion is not short, it's not really short, I think it's very difficult to assess. So maybe you think it's an overplay of this study. Maybe it was short lesions as compared to longer lesions in practice.
It's a good. I think indeed it was an excellent result in the balloon arm. Yeah. I think derived by the IVUS/OCT optimization, and I think that's an explanation. Because this performance was really an outstanding median 7. This means that half of them, they were higher than 7. At the same time, one can say, okay, maybe they put way too large vessels.
Or maybe they were not that calcific in the first place, right?
Well, I do agree that always, if you see any rotablator study or there is always an investigator bias. If it's something severely calcific, you do not put it in the trial. You use the atherectomy device. And when it is moderate to severe calcific, hodgepodge, you say, okay, well, maybe I put that in the study. So there's always a little bit of a flavor to include in the studies that are randomized in any atherectomy device. And let me remind everybody, rotablator has never won against balloon. Probably for the same reason. Whatever is, you think the balloon is not going to cross or crack the whole thing, you don't put it in the study. Say, oh, you know what, that for sure is a rotablator. Let's not put it in the trial. So you end up with this hodgepodge moderate to severe calcific, and then, the benefit is diluted, as we say, diluted.
One question from you. You mentioned that the clopidogrel is better than aspirin long-term follow-up. That's correct?
Seems so, because we know also from the very old Capri trial, even unrelated with any PCI or other biases, they had less gastrointestinal complications from 30 years ago. In a very large trial, 20,000 patients. So there was a trend always that is better tolerated. So I think it's conceivable that it may be something to do. Of course, the problem is that if a patient, or the practical problem is a patient goes for a non-cardiac surgery of any sort, then still the cardiologist has to see the patient and flip to low-dose aspirin for a week. But I think that's what I practically do all the time, and even can instruct patients over the phone to just take the aspirin, one little aspirin dose for a week, and you can actually go by that. I utilize this strategy if the patients have many stents, or if they have other disease as well, such as a moderate carotid or moderate peripheral arterial disease, and I feel that there's a more global burden of atherosclerosis.
But in this study, the inclusion criteria including this type of patients?
No. In this study simply said if you had a PCI long time ago, what can you do? So perhaps many of them have also these other vascular diseases, but I'm just saying that I don't use it routinely for all my patients after PCI to go and say, give clopidogrel forever. No, but they need a little bit higher to find some other high risk in order to energize this.
One question from Dr. McGuinness.
Yes, I will give the microphone. So, George, can I make a small question? You presented the acute coronary syndrome guidelines.
Yes.
So, But in your practice, when you have, let's say, a low-risk non-STEMI, do you run the scores? Do you do the gray score in order to investigate if there is a need to do that in the next 24 hours, the patient, to proceed to the cath lab or not?
No, we don't run the scores, really. I think you are practically, I guess you assess the score practically if the patient has many other prior PCIs and if the ST depressions are very pronounced or there is recurrent pain, then you energize emergently. But we're not going to mobilize the cath lab for any in off hours for any NSTEMI in order to make the time. I think that's a little bit excessive. I don't think we mobilize cath lab off hours. Can't wait.
Definitely, thank you.
George, how do you use the de-escalation strategy post-ACS? Do you do that? How do you suggest we should do it?
Yeah, yes, the de-escalation, I didn't go into that, and we didn't have a study actually this year. As I always described the de-escalation, it was never a trial by any sponsor or by any trialist. It was a grassroots revolution from the bottom up, from the patients. We can't afford it. That was the general message about that. And of course, initially, they don't want to hear about that. They say, oh, you know what, the trial, this trial, that. But the movement was very big. We can't afford it movement. And started from Spain, Portugal, and southern France, and then expanded to Italy. It was a Mediterranean revolution. And that's how it goes. So if there's a trouble to be compliant with this high intensity, then you have to either cut the pill in half. If you an Efient or a prasugrel, you go to from 10, you go to 5, or you go to lower dose Brilinta, or you just switch that to clopidogrel, or you drop the aspirin. There are all these different ways. So essentially, you lighten up whichever way you think is the most practical, so the patient will be compliant as well as can afford it. That was really the idea about that. It was and again, every study, every ACS study showed that a lot of the benefit from intense dual therapies was within the first 30 days. That's where the major benefit was, the prevention of the subacute stent thrombosis and the 1 month. That was a big separation. From then on, there was some benefit, but it wasn't tremendous. So if patient comes up and says, you know what, I can't afford it beyond 1 month, then instead of taking nothing or, thinking you're doing something and you do nothing, you can improvise and say, okay, well, why don't you cut a pill in half? This way you cut the cost in half. Or, you go to a less expensive agent. Or if there is some kind of a bleeding complication, you do even minor bleeding complication, nosebleed or some minor thing like that, then you lighten up in order to increase the adherence. So that's how I practically utilize it. The 1 month or 1 to 3 months, we reevaluate. I have moved away from the fantasy. I do a PCI and I write a report, and whatever I write at that time is going to be the Bible for the next year or two. I think that is wrong. We reevaluate. I say, I recommend 1 year of this or 6 months of that, and I recommend it until I see the patient again. And I recommend maybe something else at 1 month or at 3 months. So yeah, it's operational until I reevaluate it. So I think that's what we all learn from this de-escalation, that we continue to evaluate how the patient responded, is there a minor side effect, what's the adherence, and what's the financial reality of the insurance coverage and the patient. And we send them back in 4 to 6 weeks, go from there, in 3 months we readjust again, and it's a little bit of a dynamic environment.
Ευχαριστούμε πολύ. Η επόμενη παρουσίαση είναι από τον κύριο Chatzigeorgiou.